Hi, everyone. Welcome to today's national webinar and congressional briefing, Steps to Strengthen America's Seniors, How Preventing Osteoporosis Helps America's Health System. This event is hosted by the Society for Women's Health Research in partnership with the Bone Health and Osteoporosis Foundation and the American Society for Bone and Mineral Research. My name is Catherine Schubert, and I'm the president and CEO of SWHR. SWHR is a more than 30-year-old national nonprofit dedicated to promoting sex differences in disease and improving women's health through science, policy, and education. Before we move into today's program, I want to share just a few housekeeping notes. I know we've been on Zoom for years now, but it's always good to remind us all. Please note that we are being recorded and this recording will be posted online. We will be sending out the recording and any resources mentioned in the follow-up email to all registrants. All participants have been muted, cameras are turned off. This is intentional to highlight today's speakers. To ask a question to the panelists, please use the Zoom Q&A feature. Alternatively, you could use the chat function. We will be asking questions at the end of the event following all panelists' presentations. If you need technical assistance, please write in the chat function, but note we will have limited technical assistance available while the webinar is running. And finally, we are offering a live transcription feature on this webinar, and you can access that by clicking on CC Live Transcription at the bottom of your screen. And so again, we are glad to have you here and to have you join us for this important event, which is taking place during Osteoporosis Awareness and Prevention Month. Although osteoporosis is common among men and women, women account for 80% of the estimated 10 million Americans age 50 and older with osteoporosis. 1 in 2 women will have an osteoporosis-related fracture in their lifetime. Osteoporosis is also costly. Each year, it is responsible for 2 million broken bones and $19 billion in related costs, with implications for rehabilitation and long-term care. As an organization dedicated to improving women's health, SWHR is grateful to our partners and today's panelists for coming together for this conversation so we can raise awareness about osteoporosis, including its disproportionate impact on women, and drive conversations about how we, through prevention and policy efforts, can improve outcomes. I'd like to thank the sponsors of SWHR's Bone Health Program, UCB and Amgen, for their assistance in making this event possible, and again, to our partners and our panelists. And with that, I will turn it over to the moderator for today's briefing, Claire Gill, who's CEO of the Bone Health and Osteoporosis Foundation.
Thanks so much, Kathy. Welcome, everybody. Thank you so much for taking time out of your busy day to be here with us to learn more about the importance of raising awareness about bone health, osteoporosis, and the fractures that they cause. I'm delighted to be moderating today, and we have a fantastic panel who will share with you everything that you need to know about bone health in under an hour. So let's get right to it. I first would like to introduce our patient advocate, who is Dr. Tammy Denise. Reverend Tammy is co-founder and president of Carrie's Touch. It's a 501c3 nonprofit breast cancer organization. Carrie's Touch was established to enrich the lives of Black women diagnosed with the disease. As a 17-year breast cancer survivor, she has spent the past 15 years serving cancer patients and their families through the trauma of cancer diagnosis, treatment, and re-entry after treatment. Reverend Tammy's contribution to breast cancer has been recognized globally. She is an expert in the field of breast cancer and Black women and is the co-principal investigator for Project SOAR, Speaking Our African American Realities, in collaboration with University of California, Los Angeles, which examines the unique experiences of African American women who are diagnosed with breast cancer. She has also created and implemented numerous awareness, education, and support programs, such as UC Davis Cancer Center Peer Navigator Program, Carrie's Touch Breast Cancer Exposed Project, HOPE Peer Nurse Navigator Program in Ghana, West Africa, and Survive and Thrive Breast Cancer app. Reverend Tammy is also a published author, The Unmet Needs of African American Women with Breast Cancer, The Meaning of Survivorship as Defined by African American Breast Cancer Survivors, and The Power of Hope, Reclaiming Life After Tragedy. Reverend Tammy earned her degree in Human and Community Service from St. Mary's College, and a Master of Divinity and a Master in Community Leadership from Berkeley School of Theology in Berkeley, California. We're delighted to have her here to share her experience and some really important information about who is impacted by osteoporosis and fractures. Reverend Tammy, over to you.
Of course, I'm on mute, right? Thank you so much for that kind introduction. I pray that my voice holds out, so I'm going to get right into it. I want to begin by acknowledging that I am the great-granddaughter of Carrie Tompkins. I'm the granddaughter of Isella Fletcher and the daughter of Carrie Fletcher, the namesake for Carrie's Touch. And I am here today as an example of those women that have gone before me. I bring them into this conversation because part of my role here today is to expand the conversation about bone health into comorbidities. That means having more than one disease state. So if we don't know who I am and where I come from and what my culture looks like, then this conversation can get a little muddied. The water can get a little muddied. So as a 17-year breast cancer survivor, when I was first diagnosed, I was offered an opportunity to participate in a clinical trial. And in that trial, I was asked to take a DEXA scan. And a DEXA scan, you'll learn a little bit more about later from some of the bone experts, but what it does, it really does sets a baseline to look at the health of your bones. And so my doctors wanted to monitor the health of my bones throughout my chemotherapy treatment for breast cancer. Well, what they didn't tell me was that I should have had a follow-up DEXA scan to that initial DEXA scan 17 years ago. I wouldn't have my second DEXA scan for another 15 years. And by that time, I had already experienced a significant amount of bone deterioration. So you're probably asking, why on earth is this girl talking about breast cancer in a bone conversation? Well, when you are diagnosed with one disease state, what we often don't understand is the impact of the treatment on the rest of your body. And that's where comorbidities come into place. So I was battling breast cancer. Well, I'm not gonna not do chemotherapy. I mean, it's like, care for your bones, save your life, care for your bones, save your life. But what we talk about is quality of life. And while Black women are not the highest ones diagnosed with osteoporosis or even bone disease, unfortunately, we often suffer the most and succumb to the disease because of lack of awareness that we even have the disease, or lack of treatment or knowledge about treatment that it's even available, or which doctor do I even talk to about my bones? Osteoporosis and other bone diseases impact men and women of all ages and all ethnic backgrounds. So this conversation isn't just about older white women who are most often diagnosed with osteoporosis. It's about all of us. If you're human, you have bones. And if you have bones, this conversation is about you. One of the most impactful things that I heard from Claire Gill was when she said, osteoporosis is a pediatric disease that manifests as we get older. And that stuck with me because bone health is not a sexy conversation. People don't want to talk about their bones, but our well-being and our quality of life are all impacted based on the health of our bones, which we need to take more seriously at earlier ages. Other diseases that show up as a comorbidity are diabetes, cardiovascular disease, HIV and AIDS, and celiac disease, just to name a few. A report on the burden of osteoporosis and fractures commissioned by the Bone Health and Osteoporosis Foundation found that among the Medicare fee-for-service population, fracture rates varied substantially by race and ethnicity. After adjusting for differences in age, sex, and analysis, the analysis shows that the Medicare FFS beneficiaries who were North American natives suffered fractures at a rate 20% higher than the national average. While suffering fewer, while suffering fewer initial fractures and subsequent fractures, Black Medicare FFS beneficiaries have higher hospitalization rates, higher death rates following fractures, and lower bone mineral density screening rates. 2% of Black beneficiaries died within 12 months of an initial osteoporosis fracture. 2% died within 12 months? Something to look at. Exceeding the national average at a rate of 19%, as comparable rates for white, 19%, Asian, 16%, Hispanic, 18%, and North American Native beneficiaries, 18%. Medicare FFS beneficiaries who were Black were at least likely to receive screening for osteoporosis with a bone mineral density test following a new osteoporotic fracture, and only 5% of Black Medicare FFS beneficiaries were tested within 6 months of a new osteoporotic fracture. Other studies have reported racial disparities in fracture incidence and post-fracture outcomes, particularly higher rates of mortality, debility, and destitution following a fracture among Black women and among white women. We must do more to raise awareness about the importance of bone health across the lifespan of all genders and all ethnicities. We must ensure that patients being treated for other chronic diseases and conditions are aware that these life-saving treatments may also increase their osteoporosis, their risk of osteoporosis, and suffering fractions. And to close, we must be aware that necessary resources have to be made available in those community and awareness and education programs made available to those who are suffering and succumbing to osteoporosis. Thank you for your time.
Thank you so much, Reverend Tammy. I just really appreciate you taking the time to be here, because I do know that it's really scary for people as they undergo treatment for one disease to find out that there is a potential for them to end up with another chronic disease. But as you said, you really need to look at what is the most important risk you are trying to address, and address that, and then get good information and follow-up care to ensure you know exactly what's happening with the rest of your body, and particularly your bones. So let's talk a little bit more about osteoporosis and bone health specifically. And to do that, I'm really pleased that we have Dr. Suzanne Jandeber here. She's the immediate past president of the American Society of Bone and Mineral Research. It's the leading professional, scientific, and medical society established to bring together clinical and experimental scientists involved in the study of bone, mineral, and musculoskeletal research. She is also an associate professor of medicine at the Johns Hopkins University School of Medicine and the director of the clinical research units of the Johns Hopkins Institute for Clinical and Translational Research. Dr. Jandeber's clinical and research interests lie in metabolic bone disease and rare bone disease with a focus on disorders of calcium and phosphorus homeostasis. Thank you so much for being here, Dr. Jandeber. We'll turn it over to you. I think you're still muted, sorry.
Can you hear me now? Good. One. Can you see my screen or no?
Not yet.
Okay. I'm going to try this again.
Okay. There we go.
Okay. I'm sorry, I'm just having a little bit of trouble here. I'm going to try this one more time, okay?
Okay. We're actually seeing your slides. So yeah, if you want to just put them up again. Despite all of our time on Zoom, technology is not our friend, is it? What
I
seems
know it's probably also not helping too that I've got a bunch of ambulances going by. So I'm going to, let's see.
Well, while we're waiting for to get your slides up, let me just remind people as you go through, if you have questions, please feel free to put them into the chat or into the Q&A, and we will get to your questions at the end. Okay, I see your screen up, so you should be ready to go.
Thank you so much. So thank you, Claire, for that kind introduction. And I'm really delighted to be here today to share my experience as a clinician that treats patients with osteoporosis. You know, it can really happen to anyone. A slip or a trip results in a fractured or broken bone. President Biden fractured his foot while he was playing with his dog Major. A slip on the ice outside her home in Bangor, Maine, resulted in an ankle fracture for Senator Susan Collins. Both of them got recovered, gratefully, but for people with osteoporosis, a bone fracture is the first sign of the disease. And this can often lead down a slippery slope of immobility and loss of independence. The numbers in this country really are staggering. Approximately 54 million Americans either have osteoporosis or are at increased risk of fracture because they have low bone mass. And what's shocking is that most they don't even know they have osteoporosis. And even more shocking, fractures from osteoporosis are more prevalent than cancer, heart disease, and diabetes. Yet often it goes undiagnosed until a bone breaks. And outcomes of those fractures are grim. So in 2016, 1.8 million Medicare beneficiaries suffered approximately 2.1 million osteoporotic fractures. 30% of these patients who suffered a hip fracture died within 12 months, 30%. 19% of these patients that had any osteoporotic fracture died within 12 months. Approximately 42,000 Medicare fee-for-service beneficiaries with osteoporotic fractures became institutionalized in nursing homes within 3 years of that fracture. Osteoporotic fracture patients are 3 times more likely to have a fracture within the next year compared to the overall Medicare population. So outcomes of fractures are grim, and it's important to prevent them. And this problem is only going to get worse because the number of osteoporotic fractures is likely to increase by 68% by the year 2040, with an associated Medicare cost exceeding $95 billion. Each fracture costs about $20,000. Each secondary fracture, about $30,000. In 2016, $5.7 billion to treat fractures among 290,000 Medicare beneficiaries. And this is not the complete cost. That cost doesn't take into effect the significantly higher loss of productivity, absenteeism, nursing home care, and prescription medications. Fortunately, we have a tool that is more powerful at predicting fractures than cholesterol is at predicting heart attacks, or blood pressure is at predicting stroke. It's called a dual energy X-ray absorptiometry, or DEXA scan. And it's the test that's used to diagnose and follow people with osteoporosis. Yet Medicare doesn't fully cover the costs of this physician office-based test. In fact, it's been reducing reimbursements and disincentivizing its use. Every 90 DEXA scans avoids 1 hip fracture. Every 450 DEXA scans saves 1 life. 35% fewer hip fractures were seen amongst Medicare beneficiaries who had a DEXA bone test. So osteoporosis is a large problem. It results in fractures. Fractures lead to terrible morbidity and mortality, but we have a way to diagnose this silent disease. and it's a DEXA scan. But alarmingly, over the past decade, Medicare reimbursement for DEXA bone scans in physicians' offices, seen in the green line here, has declined a shocking 72%. And declining reimbursement rates have fueled a loss of about 10,000 DEXA providers and led to about 5.8 million fewer women having DEXA scans for osteoporosis screening. And this reduction in testing has especially impacted underserved communities and rural communities. So as a physician who specializes in the care of people with osteoporosis, weekly, I hear my patients telling me that their previous DEXA facility has been shuttered, or the doctor that did the DEXA no longer providing DEXA testing. This lack of accessible DEXA leads to missed screenings and loss in ground in tracking progress in osteoporosis therapy. So as a result of reduced screening due to declining reimbursements, it's estimated that there were more than 70,000 additional hip fractures between 2013 and 2019, costing Medicare $3 billion. And for many of my patients, osteoporosis is their major medical problem, but it's also the disease that can rob them of independence. And this is just not women in their 70s and their 80s. This is, for example, a patient of mine who is a physician in her late 50s, healthy, eats right, exercises daily, was shocked to find out that she had severe osteoporosis after DEXA scanning was ordered because she had a foot fracture. Without the DEXA scan, we wouldn't have known that she had osteoporosis, let alone severe osteoporosis. We wouldn't have known that she was at risk for a fracture and a future fracture. But with the DEXA scan, we could chart a course to reduce that risk of fracture and to keep her healthy into the future. We also were able to prescribe a medication that could lower her fracture risk by up to 70%. So when caught early, we have highly effective treatments for osteoporosis that can reduce the risk of fracture, similarly to what statins have done to prevent heart attacks and what anticoagulants have done to prevent strokes. There are currently bipartisan bills in both the House and the Senate to address osteoporosis screening. Representatives John Larson, Linda Sanchez, Jackie Walorski, Michael Burgess, and Lori Tron introduced House Resolution 3517, and Senators Susan Collins and Ben Cardin introduced the Senate Resolution 1943. Members of Congress who are committed to reducing healthcare costs and improving the quality of lives for millions of people living in the United States with osteoporosis should join them in this important effort. Osteoporosis is already dramatically underdiagnosed, and by creating additional barriers to screening, we're incurring more human suffering, hospitalization, and institutionalization that is vastly more costly than the $98 reimbursement for an office-based DEXA scan. By increasing Medicare reimbursement for an adequate level and increasing patient access to osteoporosis screening and preventing deadly and disabling fractures and saving Medicare millions of dollars, this just makes sense. Federal investment in biomedical and biomedical research and biological research has made an impact in skeletal health. Less than 3 decades ago, we really had very few treatment options for people with osteoporosis. Today, with many high-quality clinical trials that have established that there's available osteoporosis therapies that prevent most types of serious fractures and are thus benefiting millions of patients in the US and worldwide. Biologic research, initially funded by the NIH, was foundational in the building blocks in the realization of these very highly effective osteoporosis therapies. However, the need remains urgent for increased screening for at-risk populations and better treatment options. Continued investment in NIH is imperative to achieve this goal. We're extremely grateful for the NIH budget increases over the last 7 years, which have accelerated progress across all areas of biomedical science. We're joining more than 300 other organizations to recommend that NIH receive $50 billion in FY 2023. And this would be a $5.1 billion increase over 2022. This increase would allow NIH to continue creating more opportunities for the next generation of researchers and provide a 5% increase across NIH institutes and centers to keep pace with rapidly rising inflation while funding new grants. I'm very appreciative for this opportunity to speak to you all, and I look forward to further discussion later on in the webinar.
Thank you so much. It's really very important that we have your clinical experience as well as sharing what you see happening with your patients, and obviously research into bone disease and metabolic bone diseases, as well as other areas that are impacting musculoskeletal health is so important. So thank you for bringing that up as well. So let's dive a little deeper into the conversation about policy around bone health. There's much that's being done amongst all of the organizations participating here, both ASBMR, BHOF, Society for Women's Health Research, and many, many others, including Carrie's Touch. Dr. Denise's organization is also involved in our coalition. So we'll turn the conversation now over to Peter Reinecke. Peter serves as a senior advisor to us at the Bone Health and Osteoporosis Foundation. During his more than 20 years in senior staff positions in Congress, Mr. Reinecke played a key role in enactment of numerous pieces of health and aging legislation, including Medicare coverage of osteoporosis screening, expanded funding for osteoporosis and related research, Medicare, and long-term care reforms. He also helped lead the successful coalition strategy that doubled medical research funding for the National Institutes of Health, NIH, over 5 years. Mr. Reinecke served many years as Chief of Staff, Legislative Director, and Senior Counsel to Senator Tom Harkin of Iowa, as well as professional staff to the Senate Health, Education, Labor, and Pensions, also known as HELP, Committee, and as research director for the Subcommittee on Health and Long-Term Care of the House Select Committee on Aging. He was a member of the White House Healthcare Reform Task Force, worked for the Institute of Medicine, the National Academy of Sciences, and served as a visiting lecturer in health policy at Duke University. So Peter, over to you to kind of walk us through some of these policy issues, particularly surrounding bone.
Great. Thank you, Claire. And I'll go ahead and share my screen. Hopefully this will work. Let's see. Yeah. Can everybody see my slides now?
Yes, we can. Thank you.
Great, great. Thank you. And thank you to Reverend Tammy and Dr. Kabir too for your presentations. You know, as from my background as a Capitol Hill staffer, first I just want to thank those of you who are staff of the Hill who are watching this today. Thank you for your being here and taking the time out of your busy schedules. We know just how busy things are right now, and just your presence here today shows your interest in this topic. And I'm going to talk a bit more about the policy implications of bone health and osteoporosis and the fractures that result. It really is astounding, given the numbers that were presented to you earlier. You know, over 50 million people are impacted by osteoporosis. The projected cost of osteoporotic fractures is expected to grow to over $90 billion in just over a decade. That there isn't, you know, a lot more conversation about it within the healthcare policy debate. Part of that, I think, is that it's kind of hidden, right? And to some extent, that may reflect you know, some stereotypes that are out there that well, you can't really prevent fractures. It's just kind of a normal part of aging. You know, you get frail when you get old, and particularly older women, and these fractures occur, and you know, there's not a lot you can do about that. And when in fact that is not the case. The positive news about osteoporosis from the policy perspective is that unlike some conditions where we're still really searching for what the cause of the problem is, what are effective treatments, for osteoporosis, we know some simple things you can do from early on in life to build strong bones, get enough calcium, vitamin D, weight-bearing exercise. We also have Medicare pays for very effective medication that can build bone, and Medicare pays for very highly effective state-of-the-art screening to detect whether you have osteoporosis or a risk for osteoporosis and fracture. So we have the tools for early intervention and for treatment. We just need to make sure that we're taking full advantage of those. And quite frankly, the standard of care is there, but particularly, say, take another example in heart disease, osteoporosis, those with osteoporosis just aren't getting standard of care. And policy can be changed to better incentivize that. And I'll talk a little bit about that. But just to give that example, it really stood out to me the first time I heard this. So if you compare the risk of a subsequent bone fracture, having another bone fracture after a hip fracture, say, to the risk of having another heart attack after an initial heart attack, it's basically the same. About 8% of those who have an initial fracture get another fracture within a year of their hip fracture. And about 9% of people who have a heart attack have another heart attack within a year of that. But what happens following that is not similar at all. 96% of patients who have a heart attack go home from the hospital on a medication, typically a beta blockers, after their heart attack. And there are quality measures and evaluations in place to determine the quality of care and to make sure that they're getting the care and rehabilitation they need to stay healthy and active. However, take that hip fracture patient, only 8% get screened for osteoporosis within 6 months of their fracture. And as was stated earlier, for Black Americans, that's more like 4 or 5%. So 95% go unscreened even after an osteoporotic fracture. We'll talk more about why that's the case and what Congress can do about it. And only about 20% receive medication for osteoporosis following a hip fracture, when we know that there are FDA-approved medications that can reduce repeat fractures by 50%. So we have the tools to improve outcomes for osteoporosis. We're just not, the system really is failing these folks, and we need to take steps urgently to deal with it. So what are the policy solutions? Dr. DeBeer talked a bit about one key one, which is to improve early detection through increasing screening in Medicare. Second, there are proven post-fracture care models that are out there and demonstrated to particularly reduce rates of repeat fractures, but most people on Medicare aren't getting them. And we can improve this by some pretty easy and common sense changes. And lastly, we really do need to substantially improve the education and awareness of both the public, health professionals, and policymakers about how to improve bone health throughout the lifetime, and also to detect and better care for those who have the disease. Dr. DeBeer already went through this in basic terms, but I'll repeat just a little bit. And again, to put it from that policy perspective, and that, so Medicare, the United States Preventive Services Task Force recommends that women over 65 and older receive a bone density screening to determine their risk, whether they have osteoporosis or at risk for osteoporosis. So that's the good news. The bad news, as Dr. Beer said, is that the payment rate for Medicare, particularly for those provided in doctor's offices, which are obviously the most convenient typically for patients. They're in there, they're seeing their doctor for their annual visit or some other reason, go in and get your DEXA screening right then and there. However, because of payment cuts since 2007, the number of screenings provided has dramatically reduced, been cut. And as a result, many hip fractures have gone undetected, and that has also meant that they've been the detection of them have been delayed, which added to cost to Medicare of over $3 billion. An estimated 1.65 million undiagnosed and untreated osteoporosis just in 2019, and 5.8 million fewer women have received a DEXA than would have been projected in 2008. So it's really inexcusable that the payment rate for particularly the doctor's offices screenings are so inadequate, and even compared to what is reimbursed when you get the screening done in the hospital, which obviously is much less convenient and requires travel, so therefore is less utilized. So as Dr. DeBeer mentioned, there is active legislation that the Bone Health and Osteoporosis Foundation and ASBMR and the Fracture Coalition have been working very hard to get passed. There's strong support in the House and the Senate. It's bipartisan. Representatives Larson and Walorski are the two sponsors in the House. There's 62 bipartisan co-sponsors. Pretty rare for legislation these days to have pretty much equal Republican and Democratic support. In the Senate, same thing. There's 16 supporters of the Collins and Cardin bill, and it's under active consideration now by the Senate Finance Committee. It's also before the House Energy and Commerce and Ways and Means Committee. So if your boss is a co-sponsor of this, thank you for their support. Please urge the committees to take action on this. This really should be done in a way that can actually even save the government funding, because we know early screening prevents costly hip fractures in the end. And so this should be a no-brainer to get done. It's in line with the shared goal of improving prevention and early detection. And the human benefit of it is so clear. The other item is this model post-fracture care. It's often referred to as fracture liaison service. And most of the 1.8 million Medicare beneficiaries who suffer an osteoporosis fracture do not have access to this FLS. Basically what it is that there's a team that is made available to someone right after their fracture. They would go in and they follow a protocol with a coordinator that makes sure that they are screened for osteoporosis, make sure that they've given instructions about exercise and ways to reduce falls, but also get evaluated for that medication that we know can be effective, and if appropriate, get it prescribed and get them started and get them monitored for staying on that medication. And they're using established protocols to ensure that they get appropriate diagnosis, evaluation, secondary prevention, treatment, and support. And as I've said, this FLS is not just an idea, it's a proven mechanism. Leading health systems, Geisinger in Pennsylvania, they found that they were able to get treatment rates up to over 75%. As I mentioned before, on average, it's only about 20%, but shows that you can get treatment up if you give adequate post-fracture care. And what were the results? They actually saved $7.8 million in their 5-year period. Kaiser, same thing, their Healthy Bones program reduced hip fracture rate, expected hip fracture rate by over 40%. So think about the number of people that were prevented from going into nursing homes, lost their independence, and also the cost of those subsequent fractures saved. Kaiser estimates a similar effort could reduce the number of hip fractures nationally by over 100,000 and save over $5 billion a year. A similar AOA effort called Own the Bone at over 190 sites around the country led to much higher rates of screening and treatment, with over 60% treated for osteoporosis after a fracture again. So they tripled the rate of screening on average nationally for osteoporosis. So it's clear if we made more Medicare beneficiaries, gave them access to this post-fracture care, we can dramatically improve outcomes, prevent people from having to get into nursing homes, and also save Medicare funding. There's a broad set of stakeholders, including BHOF, ASBMR, and all these other organizations that have come out in support of in a presentation to CMS, and CMS is actively considering a proposal that would alter their payment codes and create new codes for this FLS post-fracture care model. And the hope is that this will be done as part of their annual update in the Medicare physician payment system. So we're about 14 national consumer and women's health and bone health and aging family caregiver organizations have also sent a letter to the Congressional Appropriations Committee calling on you to Congress to urge CMS to do this in the name of good care and cost effectiveness. So we're very hopeful that this CMS is going to move in this, and hopefully we'll know this next month. The other step that I mentioned on the public policy front is the real need to greatly improve education and awareness about bone health and osteoporosis. BHOF led an effort that we're pleased to say has resulted in 8 states: Georgia, Maryland, New York, Wisconsin, Illinois, Nevada, Pennsylvania, West Virginia, taking step by either legislatively or through executive proclamation to call for greater awareness on bone health and osteoporosis and designate May this month as Osteoporosis Awareness and Prevention Month. So we're very pleased at thank the states for their efforts to do this, and we are going to be working to build on this to get other states in the coming years. Also, BHOF and the Policy Institute and the Coalition to Strengthen Bone Health, which Claire mentioned, again, which Society for Women's Health Research, ASBMR, and over 20 other national consumer organizations are members of, are working to increase the importance of bone health throughout the lifespan in a range of educational efforts. If some of you may have heard, CDC has been supporting for about a decade now the Million Hearts campaign to raise awareness about heart health, and it's been very successful, both in educating health professionals and setting national goals for improved heart health outcomes. And so we are working to get CDC to start a program modeled after Million Hearts on bone health. And we need Congress's help to do that. And we're hoping, again, that the Appropriations Committee will include $1 million to start such a campaign in their fiscal year 2023 appropriations bill for HHS. BHOF is also working with CDC and USDA to get bone health and the materials we have developed about bone health education more available to the millions of Americans who participate in existing nutrition education initiatives through the Department of Agriculture. Millions and tens of millions of Americans get nutritional help from the Women's, Infants, and Children's Program, School Breakfast and Lunch Program, the Supplemental Nutrition Program, and there are educational efforts that are associated with these programs, and we're now working with USDA. I'm very pleased to be doing that to try to get bone health information to those participants so that they can be taking steps early on in life to improve their bone health. As we said, there are basic things you can do. For, my kids now are at the prime age, their early teens, for making sure that they're going to have their peak bone mass by the time they're in their early 20s. And so we need to be getting them the nutrition, which they need to be, what kind of foods and any supplements they may need to build their bone health, the kind of exercise they need throughout the lifetime. So there's so much that can be done, and we appreciate members of Congress and their staff for their attention, and we look forward to working with you more in the coming weeks and months and years. Thank you.
Thanks so much, Peter. Really appreciate that. I know that was a lot to cover, but as you can all see, there is much to be done. There is much currently underway, which is terrific. And we need all of you, both the members and staff of Congress, as well as all of the associations involved in this webinar to participate and get involved. So let's now take some time for question and answers. And I have seen a bunch of them coming through on both the chat and the Q&A. So I'll invite all of our panelists to come back on screen, and we will take a few minutes to answer some of these questions that have been posed. So let me start with some basic information that I think people might be curious about and be wondering about. So when we talk about DEXA reimbursement and scanning, which again, it's one of the basics, as we've seen, on diagnosing people with osteoporosis, and yet this issue has been around for a number of years. Many people participating saying, again, that they've known that this kind of issue and coverage has been happening since the 90s, which is true. We've sort of gone up and down on that. So let's talk a little bit about, first of all, with you, Dr. Jandaber, about what it takes to sort of maintain the DEXA machines. Why is there such an issue with reimbursement? And then Peter, maybe you can talk a little bit about the policy impact, or I could, from the Fracture Coalition.
Yeah, so I'll just give you a little bit of background. So DEXA machine, it's typically is either in a hospital-based setting or a doctor's office. And as Peter said, it's really a great setting to have it be in a doctor's office because it promotes that health screening. And it gives more availability to people in the community to be able to get that screening with the DEXA scan. You need a technologist to run the DEXA scanner, and then you need to be able to read the DEXA scans. So currently, office-based DEXA reimbursement is in the $40 range. That is just not tenable financially to be able to purchase a $50,000 piece of equipment, hire a person to run it, and then spend your time as a physician reading the DEXA scan to generate a DEXA report to then be able to serve your practice and people in the community. So DEXA scanner reimbursement had been higher in the past, where you could actually, make ends meet and actually offer the service without losing money. The current reimbursements are actually, you can't break even in offering the service. Is that what you needed?
Yeah, that's exactly what I needed. And
Yeah.
so, Peter, in your experience then, as being a staffer on the Hill, what are some of those things that are needed for us to kind of advance this for us? So we're talking about, you know, we need a CBO score. What are some of the things that you think are necessary to put in place to kind of get this legislation passed?
I think that the impact of the reduced screening and getting those, both the numbers and the personal stories, I think is key. You know, members of Congress and their staffs, you know, they're first and foremost humans, and my experience is that those personal stories can make a big difference. But when it comes to things that may cost money, you're right, the Congressional Budget Office score is an essential need in order for a bill to move through the final process. And as I said, this is not, shouldn't be something that would be a major cost, and in fact, could be a cost saver if CBO were to take into account reduced rates of fractures and even, you know, tougher to account for the savings, like for example, to state Medicaid programs through reduced nursing home admissions, which are the biggest driver of state budgets, nursing home costs. So I think getting that report from CBO will be crucial, and also having clear bipartisan support, which this measure does have. So I think a number of the elements are there for this to happen. It just has to be, you know, pushed by some members of Congress who say we're gonna make this a priority, and we're not gonna be quiet until you give us an answer on moving this. So it's a matter of just keeping that pressure on and having champions on the Hill to push it through.
Yeah, so important. So obviously this will not be the only conversation we're having with all of you about this topic. And we really do hope that we can engage more in meaningful conversations about how to get this legislation passed before the end of this year. It really is essential. Let's go back to some of the questions that I've seen come through. One of them is, as we talked about some of the differences between the cardiac and bone, and the fact that it's pretty easy. If you have a heart issue, you go to see a cardiologist, but with bone, that's not the case. And sometimes it's confusing. So Dr. Jandaber, can you kind of go over what are the types of clinicians that can see an osteoporosis patient? And then we'll talk a little bit more about, you know, why is there some confusion between the groups about post-fracture care?
Yeah, so there's a wide variety of physicians that, you know, can touch skeletal health. So for example, for many women, their primary doctor is OBGYN doctor. So there's plenty of doctors in that specialty that are interested in screening women and treating women, but not everybody in that specialty thinks that that's their bailiwick. So I think, you know, OBGYN, primary care physicians, another, you know, place where people have many touches for their healthcare. Again, looking at it, you know, we perform cancer screening, and we see that as in the purview of the primary care physician. This would be a screening procedure to try to see if someone has osteoporosis. And as we said, Medicare will reimburse for it, everybody over the age of 65. So there's no barrier to performing that screening. Other doctors are orthopedic surgeons. You see those people when you actually break a bone. And as we said, osteoporosis is a silent disease, and many times people don't even know they have it till they've fractured a bone. And the people that help treat bone fractures are orthopedic surgeons. The orthopedic surgeons have been raising awareness amongst their ranks about understanding, like, this is, you know, the equivalent of a heart attack for the skeleton. It's a skeletal heart attack. And then that needs, you know, urgent addressing. So primary care physicians, OBGYN, orthopedic surgeons. And then when you're getting to more specialty care, you'll see rheumatologists may be involved, endocrinologists, which I am, may be involved. So there's a variety of physicians that I think we need to raise awareness about and really talk about the importance of screening for this silent disorder.
Yeah. And so let's talk a little bit, just continuing this about the specifics of osteoporosis and diagnosis and DEXA scans. There's a lot of questions about the definition of osteoporosis. And I know that there's been recent papers that we talked about, at least under our the BHOF clinical guidance is talking about anyone over the age of 50 who fractures should be considered osteoporotic and should be followed up with. But again, what Medicare focuses on is 65 and up as that. So can you talk a little bit about, what patients should talk with their clinician about if they think they need to get a DEXA scan done earlier than what the guidelines are for Medicare?
Yeah, so I completely agree with what you're saying, Claire. So I think, women over the age of 65 and men over the age of 70, even in the absence of any type of fragility fracture, should be screened for osteoporosis. I think individuals over the age of 50 that have suffered a fragility fracture, and that is a fracture from standing height or less. So for example, you could say, oh, well, my dog pulled me off the curb, but that's really still from a standing height. And if you fractured your ankle, or you fractured your spine, or you fractured your arm, or you fractured your hip, or you fractured your leg, fingers and toes don't really count, but those other large bone fractures would definitely count. That would be something that you would want to get DEXA screening for and be considered for treatment for osteoporosis, because as I said, a fragility fracture like that is the equivalent of a skeletal heart attack. It's not normal for someone to fall down and break a bone without, falling off a 6-foot ladder, that may be normal to break a bone, but falling off a curb or falling from a standing height is not normal to break a bone.
So true, really important. And, again, I think it's important for patients to think about the fact that if they know there is a family history of osteoporosis, that is something that you absolutely have to bring up with whatever healthcare provider you're speaking with, because that would be something that would be able to put you at a higher risk, and therefore, your clinician might be able to get you a baseline DEXA at an earlier stage. We talk often about the impact of menopause on bone, and I know there were several comments and references to that in the Q&A, and why, first of all, do women not know that dramatic bone loss happens at the onset of menopause? Women can lose up to 20% of their bone and the bone density in the first 5 to 7 years post-menopause. So it is a critical time. But again, there's specific guidelines on when things can happen and why. And so you really need to speak with your clinician about other risk factors you might have that would allow you to get a bone density test done earlier, and they can absolutely help you with that. We'll come back to more of those bone density and DEXA questions, but I'd like to ask Reverend Tammy, and I know obviously you can't speak for the whole Black community, but one of the things that came up was questions about what do we do with people who are lactose intolerant, and many Asian and people in the Black community are lactose intolerant. So what are some of the steps that you advise women about how to get calcium, the recommended daily calcium that they might need?
Yeah, well, in addition to supplements, and I, of course, do not speak for the entire Black community, but in addition to supplements, knowing what type of foods and where you can get calcium, excuse me, in various foods and such. Sorry. And that's really my biggest thing. I did want to jump in the conversation, from the patient perspective as well, because when you're in a doctor's office, it's not just the doctor in that appointment. It is the doctor and the patient in there. And for me, those conversations are enhanced when you have positive patient-physician relationships where there's trust among each other, and they understand that it's a co-decision-making process that they are aiming to reach, because the patient feels like their doctor has their best interest at hand. So it's not just the doctor coming in with all of this medical information or understanding some of the complexities around policy, but it's the patient also coming in, being able to ask, feeling comfortable asking necessary questions to make the best decisions about their health, their treatment protocol, and their well-being. There's so much to cover in a 15-minute doctor appointment. And we teach patients to find out what is your biggest concern. So if I'm going in there for cancer, but today my biggest concern is the pain in my right hip, I've got to make that a priority to let my doctor know that, and then feel good asking the doctor, what are my options? What are the most advanced options available for me? And my experience has been that when that happens, you have a more engaged physician and a better outcome for the patient in that conversation in that room.
You're absolutely right. Yeah, and I think we all get overwhelmed sometimes. Again, you're on a timetable with the clinician, right? That they have limited time. I think all of the organizations involved here on our websites have information about, checklists and things that you should do to prepare for your doctor's visit. And that's great advice, Reverend Tammy, is that it really is, I think more and more, we're seeing clinicians understanding that they have patients who are coming in who are much more educated about some of the things within their care. And so one of the things that I thought was really important that came up recently in one of our clinical programs was healthcare providers saying, come in with your list. They love that, right? When you have a written list, because then you don't forget, oh, I forgot to mention the pain in my hip and such. And as I said, we kind of get overwhelmed. But the other was, if you're coming in for a specific issue, it's not helpful to tack on the conversation that might take a lot more time, because the clinician has looked at your appointment and said, oh, I'm going to address a breast cancer concern today. And then they built that time into the appointment. And then you've got a lot of issues about what's going to happen to me now, or chronic issues about bone, et cetera. And so they also recommend that you call and set up an appointment specifically to discuss that. Right. And that's something that we talk about. We kind of go with a well woman visit, for some of us, and we just sort of dump everything that we have, and we wonder why we're not getting a satisfactory experience in 15 minutes. But we really need to prioritize as we go into the clinicians and say, here's what I absolutely have to cover with you today. And if I need to come back, or we can have a phone consultation, I also need to address these things. I think that's really important. Dr. Jandaber, do you have any other suggestions along those lines?
I think those are great ones. I think really don't let the thing that you want to address be the last thing you talk about. Come right up front. I agree with Reverend Tammy. You want to set that agenda together. You want the patient to drive the agenda, like, this is what I need help with. Let's discuss this. Let's put this forefront. And then if we need more time, we can set up more time later. One thing I also wanted to say that speaks to what Reverend Tammy was saying in her presentation, and getting back to the reasons to get screened early. Certainly many breast cancer therapies that deprive you of estrogen are reasons to get screened early and reasons to address your bone health early. So I just wanted to put that in there as a nod to the important things that Reverend Tammy's been saying.
No, that's a good point. I think we have time for a couple more questions, so I'm going to try to get through a few of these. Peter, there's a specific question sort of along the lines of our Millman data. When we talk about fractures and people dying within 12 months, there is that discussion that they, what did they die from? It's often not listed as osteoporosis even, but part of that, the figures we're looking at people who had fractures and how did that move them towards mortality at a quicker pace. So what percentage of death what were some of the things that we considered in the Millman report about, other causes or other things that led to the deaths post-fracture? Do you remember the specifics on how we had them calibrate that?
Yeah, I'll get to that. Can I just jump in from that earlier discussion too, just from the policy perspective, and obviously from the patient perspective, that need to be a good advocate for yourself, but also, we can't lose sight of the fact that Medicare and taxpayer dollars are paying for this care, and you've paid in for this. If you're on Medicare, you paid into it for your lifetime. So you do have some right to be able to expect that your tax dollars are going to result in you getting, what is the standard of care for the health problem that you have. And so while you need to be your own best advocate, government policy can and should have a responsibility for making sure that the system isn't failing you and that the system is incentivizing the providers to provide you standard of care, and so policy does drive, and incentives do drive behavior on the part of providers, and also quality measures and others can also help to drive some responsibility and measurement of what is being made available to Medicare beneficiaries. So that's part of the Policy Institute's agenda. But so for the specific Milliman report, I think they screen for things like age and other factors. So you can't, the cause of death isn't typically on the autopsy report, or osteoporosis or fracture, but it can also be pneumonia, for example, or heart failure that might have been related. So there's no way to have a specific, we ruled out everything else that could have occurred to the person if they hadn't had the fracture. But it's clear from the cost data and from the outcomes data that it's substantially contributing to these adverse outcomes, including death. There's no denying that from the data.
Yeah, it's something, it's really hard to, especially when we're tracking fracture stuff too, and fracture outcomes, looking at, particularly as we said, people have so many comorbid conditions, it can kind of get things complicated, but we do know, we call it the downward spiral that happens after someone has a fracture. And so that's really what we're monitoring for. Let me do one more question. This is again back to that sort of question about menopause and related, but the impact of estrogen on preventing osteoporotic fractures. Dr. Jendiber, can you cover that a little bit again about why that happens for women at menopause?
Yeah, so like you said, when women go through the menopausal transition, there is a rapid bone loss, and you can lose up to 20% of your skeletal mass, which is a lot. And that increases risk of fracture during that time. So there's so your bone density is here, and then all of a sudden you have this big drop. And then as women age, and as we all age, we lose bone density over time. So where you start is really important, because you're going to lose bone during the menopausal transition, and then you're going to lose bone as you age. So, hormone replacement therapy can help during that menopausal transition. It can help reduce bone loss, but there's other considerations that you have to take into consideration when you're talking about hormone replacement therapy. So my rule of thumb is, if there's hot flashes that are debilitating, or other menopausal symptoms that are just very disruptive, sleep disturbance, problems with vaginal dryness, other issues that you can use estrogen to treat that will also preserve bone mass. To me, that's a good risk-benefit ratio where you're getting multiple benefits. But you have to weigh that against, the slight increased risk of breast cancer, and really put it into context of the woman that you're prescribing it to and what her personal and family history is.
It's true. Medicine has become so personalized, and we need more of it, right, to really address this. And we're always thinking about that. Treat to target is a common thing that's come up amongst the clinical community. I think patients are understanding that as well now too. I see Reverend Tammy, you nodding your head, right? Because it really is, who are you, and what are your issues, and then what are the best approaches for you? And I think that's going to be really more important as we continue to work to improve the health and well-being of not just women, but all Americans. We're running out of time quickly, so I just want to first of all thank everyone for participating, and I would like to ask one final question of each of our panelists. If you could share your thoughts on the one thing you would like people to take away from today's presentation, and I'm just going to go in the order in which we started. So Reverend Tammy, I'm going to start with you.
The one thing that I would have patients to take away is that you actually do have more power than you think that you do. So I speak from a community that has had a history of trauma in, the medical professional, but most medical professionals really do want to see you well and healthy, and you have more power than you think. So use it in your doctor's office.
That's a fantastic comment. Over to you, Dr. Jennifer.
Yeah, I want people to know that osteoporosis is silent. It needs to be screened for. And if we identify it when it's screened for, we have very effective treatments that can prevent fracture, which have very bad outcomes. So that was my takeaway message.
Thank you so much. And Peter. Oh, you're muted, Peter.
Sorry, thank you, Claire. My takeaway message for the Hill staffers is this is a big healthcare problem that the Congress and the administration could take some very basic common sense steps. One, improve access to screening. Two, better incentivize proven methods of post-fracture care coordination. Both those steps would dramatically improve outcomes and reduce cost for people on Medicare. And they really are quick, two easy things that can have big outcomes that could and should be done this year.
Thank you so much. Again, I want to thank the Society for Women's Health Research for inviting us all to participate and for hosting this opportunity to talk more about the importance of bone health and how it impacts so many other diseases and areas of women's health and men's health. Let's not forget. And thank you all for taking the time to be here. We appreciate it. If there's anything else that you have questions about, please feel free to reach out to the Society for Women's Health Research or any of the organizations here. And Kathy, I'll turn it back over to you for the closing.
Thanks, Claire. Thank you all for this wonderful discussion. So much here, particularly in the chat, we're seeing right about what women need to know earlier. I think that's really important. As we mentioned, the materials and the recording will be sent to you all following the event, and we encourage you to look at the website page for today's briefing. It includes SWHR's new fact sheet on bone health, the National Osteoporosis Foundation's Medicare cost of osteoporotic fractures report, and other bone health resources. And so thank you all for joining us today and have a great day.